Well, thank you very much for that introduction, and I am also very pleased and privileged to be here. I think back 19 years to the beginning of the Cochrane Collaboration, which was started with fewer than 100 people, and as you'll see, has progressed to many thousands now being involved. But it was a very tiny group, and as the Chinese remind us, every long march begins with a single step. So I think if you can capture the excitement that was reflected in the early days of Cochrane, then Nijmegen, is that how you pronounce it, can become the new Oxford, because it was started in Oxford by a tiny group. So this debate goes on a long time. 1,000 years ago, Ibn Sina was talking about the difficulty of translating from human to humans from animal work. And in modern times, we've had this infamous situation where TGN 1412 was examined in 6 patients in London, just northwest of London, and 6 healthy volunteers suffered incredibly bad reactions from a cytokine storm. And this was a serious example, but it was only also one example of failure of animal research to predict what was going on in humans, even research done in primates. Interestingly, Medline has actually no papers on this topic until 2006, and all the papers after have been about this incident. So although animal research was done, it was not reported, and certainly there were no systematic reviews. Another drug called hexamethadone was tried at Hopkins. That was another example where, actually in that case, a patient died, and when the Human Investigation Committee investigated the death, they found that the investigators had really failed to do a correct review. Certainly they'd not done a systematic review either. So what we're talking about does have very serious implications. So the key question, I think, is why are animal studies poor predictors in medicine? Obviously, of all the hundreds of thousands of animal studies that get done, some do predict quite well what the human reaction will be. That would happen purely by chance. But the prediction is actually quite poor. So these are some of the reasons why. Many animal experiments are poorly designed and performed. It's inadequately reported. There are not enough systematic reviews, and I'll bring those 3 themes back in a few minutes. I think in what's turned out to be a fairly influential paper by Pandora Pound a few years ago, this was where Ian Roberts and myself and others looked at the animal literature. I think as I remember, we found 27 systematic reviews. But the main benefit of this paper was to point out some of the problems in the animal experimental methodology. So let's have a look at what these were. Different animal species and strains used, all of course having different metabolic pathways, different metabolites, and variations in efficacy and toxicity. Different models of inducing injury or illness. One area I know a little bit about is spinal cord injury, and in the animal model, that's done by dropping a weight. It's a very reproducible animal injury for producing paralysis, but it's not how human paralysis is caused. It's quite different. Other illnesses are induced in different ways as well. There's variations, of course, in drug dosing. In animal work, you have the advantage of pre-dosing animals before you induce an injury or an illness. It's important within the context of an animal model, but it's not predicting what the human response might be. We've got variability in how animals are selected for study. It's certainly rarely done by randomization, and the comparisons are often not reported. They're often not placebo, and the issues of loss to follow-up are badly done. The experimental groups are often small. There's poor power to actually look for effects with any robustness. And the statistical analysis is often quite primitive. And the intent to treat principle, which is always, well, not always, it's recommended for use in trials, is widely ignored. This is where animals that don't meet some expected outcome are actually dropped from the analysis rather than being taken into account. So just a couple more. There are many nuances in laboratory technique that can influence results that are not recognized or reported. And a common one is whether investigators were blinded. And then a selection of outcome measures which may be disease surrogates or precursors of disease that again have uncertain relevance to the human condition. And finally, length of follow-up does not correspond to latency of disease in humans. So what are the goals of systematic reviews in animal research? The first one of any meta-analysis or review is to try and increase the precision of estimating treatment effects that you might anticipate in human trials, reducing the risk of false negative results. Depending on who you talk to, about only 1 in 6 or maybe 1 in 8 of human trials now actually come up with a result that people are hoping for, which is that you're finding a drug that's efficacious and safe. Animal systematic review should illuminate the process of actually translation from animal to clinical research. And they should tell us about the appropriateness of the animal models being used. And we should be able to compare results of animal and human research to see how well actually one does predict the other. So what Cochrane has taught us is simple, but it's actually incredibly profound. I think I'm quite confident in saying that the science of creating modern systematic reviews has been done through, and it continues to be done through the thousands of participants who actually comprise the Cochrane Collaboration. PubMed, I think, did not classify meta-analysis until 1990. Now, there were certainly older meta-analyses in the literature, but PubMed did not have the foresight to actually use that as a classification. But in 1990, 273 meta-analyses suddenly appear. And if we go forward in time, we can see that now we're up to about 4,000, just over 4,000 publications in 2010, which is the last complete year. 2011 is PubMed still being populated. And if we look at it a different way, this is the number of systematic reviews per single publication. So there are about almost 90 systematic reviews for every 10,000 individual publications. And that's climbed dramatically from just over 200 back in 1999. And this is in humans, the red line. The blue line is looking at the animal systematic reviews, meta-analyses, and it certainly was climbing a bit in 2007, but it's peaked. It seems to have peaked at 2009 and flattened off, which is, I think, a bit discouraging. But there are 10 times the number of human reviews per individual paper than there are animal reviews. And those of us who do human reviews will tell you we think we're underperforming for human reviews. There's still enormous amounts of human literature to do systematic reviews on. The animal researchers are way behind. This is what an animal systematic review, actually I should say should look like, because I think this is one of the rare specimens, and it's a model for doing this kind of work, and it's great that Malcolm is here, and I hope I'm not stealing your thunder, Malcolm. But this is the typical first figure of these reviews, where it looks at all the comparisons. This reddish line here is the estimate with the 95% confidence intervals. This is the null. So most of these studies are showing evidence for a protective effect from this particular drug, but the estimates vary very widely. And what you can do, what they did, is looked at a number of interesting things. So drug dose, that again is a typical estimate there. And you can look at the range of drug dosing, or when the drug was given in response to injury. So these are the pre-treatment conditions. But I think what this study was really important for was the group developed a 10-point scoring system, and for the quality of these studies. So if you look at blinded therapy, only one study managed to do that. If we look at another important methodological factor, blinded assessment, only 2 studies did that. We actually have one study that managed to achieve none of these 10 quality criteria, and the highest scoring one got 7. So this one here. So I would venture to say this is not an unusual result if one wanted to use the same sort of quality score on an animal review, and maybe we'll hear more about this. Why this matters is shown in this figure from the same paper, and again that's the typical risk estimate, but you can see the lower quality scores down here are producing much greater effect sizes than the high-quality studies. And this is seen, this type of association is seen now in many, many human analyses. It's almost like a law of nature. But if you do a review, the low-quality studies will show you stronger effects than the high-quality studies. So this is from an Oxford view of tutorials, but I think it nicely captures the attitude of people who do systematic reviews. No beliefs are unquestionable, no statements safe from scrutiny, no evidence is incontrovertible, and no conclusion is inescapable. We go into doing systematic reviews, hopefully with a completely open mind. I wanted to show you a couple of reviews from my own students. These are not Cochrane reviews, although they use Cochrane methodology, they use RevMan, but this is one looking at this particular polymorphism and looking at is it protective against asthma. So a typical review showing you each of the studies that looked at this and the effect for each study, and then the diamond now, which is this sort of iconic shape that's used in meta-analysis for the typical estimate. So showing here about a 30% reduction in risk for childhood, it's actually childhood atopic asthma with this particular polymorphism. Here's another one. This is looking at something called CNVs. These are where the DNA is either deleted or multiplied. This is the null. This is showing increased risk for autism with this particular deletion, and it's the most common one. The point of this paper actually was to look at whether you could use this for screening purposes for autism, and the conclusion is that you cannot. Even though it's a very strong, statistically significant result, the prevalence of this is still too low to make it useful for a screening tool. It's another use of meta-analysis. And we've used it in looking for chemical expressions, prognostic risk factors for breast cancer and for melanoma. So it's widely used. These are not clinical trials. You don't have to be doing clinical trials to do systematic reviews. many of us think you can do systematic reviews of absolutely anything. This is one that I picked deliberately, and it's looking at a question of, do people who are born with low birth weight, is their adult mortality influenced? So it's looking at many thousands of subjects in a number of different studies. These are the summary statistics, and so all-cause mortality is at the top, and it's actually showing an effect on adult mortality for people who were born low birth weight. But what's quite interesting, the effect is mainly in the cardiovascular mortality, and it seems to be, if anything, slightly reversed for cancer mortality. So this is part of what's called the fetal origins of disease hypothesis, and I picked it because some of the most important evidence of fetal origins of disease comes from Holland, from studies of the famine populations in the Second World War. And so this actually provides some evidence for support for that hypothesis. So how do we look at systematic reviews and make decisions about whether they are valid reviews? Because like everything else, systematic reviews come in different levels of quality. Not all systematic reviews are necessarily very good. And you've got to be careful when you see these in the literature to make sure they're really systematic reviews. Do they have a methodology? I mean, people have gotten used to hanging systematic review on the end of a review and sort of pretending it's systematic, and many times they might not be. So PRISMA is the statement that's been developed for reporting systematic reviews and meta-analysis. It came again out of the Cochrane Collaboration. A lot of people working on this were Cochranites, as they're called. And it's already under re-review now by something called Messier. This is still in process within the Cochrane Collaboration, so I'm going to talk about PRISMA. So in introducing a review, you want to explicitly outline the clinical or public health problem, or in your case, it would be the purpose of the experiment. What's the biological rationale for the intervention that's being used? What's the rationale, in fact, for doing a review? So the hypothesis is probably the most crucial part of a systematic review, just as it is for doing a trial or any other type of science. And systematic reviewing is a hypothesis-based enterprise. So in the clinical world, among patients with a specific type of disease or type of patient, this is what the review is going to be about. In your world, you'll be saying among mice of a certain kind of strain, or mice who've been genetically modified and been injured in a certain way, perhaps, or given a disease in a certain way, what kind of treatment given in a certain way compared, because there's always a comparison. Maybe you're comparing to placebo, maybe you're comparing to nothing, maybe you're comparing to another therapy, produces a specified outcome. Now, systematic reviews come in two general sort of typologies. One is a very broad-ranging systematic review, where you might be looking at a whole group a generic group of medicines, let's say steroids, and how they impact a fairly broad range of disease. So you're systematically reviewing a large area, and then you subgroup more specific comparisons, or you just make the whole review much more focused, and you talk about a specific type of drug and a specific type of injury or phenotype, something like that. But this is where that is all laid out. And without getting this right, you will never go on and do a good systematic review. Now, when I'm teaching this, I'm telling students, reduce it, make it more focused, because everyone comes into this with thinking they're going to do a much bigger review, sort of a how can I cure cancer type of review. I think it was Martin Ryle who said if you want to make an apple pie from scratch. First, you have to create the universe. So, it depends on the level of the question. But I think generally, and certainly in the Cochrane review group that I work in, the neonatal review group, we've tended to narrow down our questions. We also think that's how people use the Cochrane Library. Our belief is they go to the Cochrane Library with fairly specific questions, not with these more global questions. Now, perhaps that's not correct, but that's our perspective. So it's another rationale to do more focused reviews. In searching, so if in a systematic review, you need to be very explicit about how you've searched, which databases, what are the dates of the databases, did you use any language restrictions, and certainly in Cochrane, these are not favored. We do not want language restrictions. But imagine doing a review in acupuncture and just limiting it to the English language. You'd miss 80% of the literature. And then there's a whole system of how do you validate each of these studies, and how do you actually pull out the data. So issues about study design, who are the participants, and then there's this whole process of data synthesis or meta-analysis. You can do a perfectly good, useful, valid, systematic review and never get into meta-analysis, and I'll explain why in a minute. Systematic review is not synonymous with meta-analysis. If you've done your data collection and you've got a nice set of studies, yeah, you do meta-analysis, but you don't have to, and you can be very useful doing a systematic review that does not include a meta-analysis. So there's a search flow that's documented. I'll show you an example in a minute, and a description of how you're going to look at these data. So this is now what you expect in a systematic review, how many articles you initially screened, why you threw out, in this case, 24 of them right up front, and then you looked at this next 124, and in more detail, you excluded a bunch more, and you finish up with 76. Should be very explicit in a review why you've got to this. Very different from a traditional review, where none of this is obvious. You don't know in a traditional review why these authors are focusing on a certain group of studies to review. What happened to all the other ones? This is why it's important. We'll pick Nature here. So if Nature's reporting on 7 studies, but in fact 26 have been done, then that's what Nature's reporting on and missing all of the other literature. And I don't have to tell you why these are likely to be focused on and these are likely to be ignored. How do we suspect studies might be missing? If all of these dots are studies, we're ranking them here on sample size, and if the typical risk estimate is about 0.8, we would expect these studies to cluster around the typical estimate. Well, you can see, I think, that it looks like there are a few studies are missing there. And they're missing because of publication bias. These studies might well have not been, if this is a drug that people are interested in because it might be protecting against something, the studies that actually show risk are going counter to the hypothesis, and they are tending not to be reported. It's very hard in human studies to hide these very large trials, so they will almost always be reported. It's the smaller studies that get missed. This is an example from gene polymorphism. You can see this is a very, very large study of about 20,000 people, so we think it's providing close to the real estimate, but all these studies got missed. These were studies that would have shown a protective effect when the people working in this field were expecting a risk. This is an example from gangliosides in reducing stroke. I don't know if this is from your group, Malcolm, or not, but this is where these studies look like they've been reported, but there's a bunch of studies missing here. So there's a method called trim and fill. The red ones are where these data have been forced in, but you can see how it reduces, in this case, the risk estimate even closer to 0. So let's talk about meta-analysis. We're trying to assess the strength of evidence to determine if an effect exists in a particular direction, trying to improve power and precision of those 95% confidence intervals. So if we can do some pooling, we will. We worry about heterogeneity, and I'll talk more about that. A good systematic review may be able to answer questions not looked at in individual studies, and it may also be able to generate new hypotheses. When not to use meta-analysis, if there's substantial variations in the exposures that being used, or if the populations are clinically very diverse, or if the outcomes are too diverse, then it may not be appropriate to do a meta-analysis. If the studies are of poor quality, there's no point in doing a meta-analysis. And if you suspect serious publication or reporting biases, it may not seem worthwhile to do a meta-analysis. So for each of the studies that's going to go into it, we calculate a summary statistic, and then we calculate the pooled average. That's the diamond shape that I talked about at the bottom. The statistics for doing meta-analysis are pretty basic. There's nothing straightforward. These are nothing not straightforward. And these are the dichotomous data estimates that we look for. Relative risk, if it's a truly prospective study, like a trial, and risk difference, and then number needed to treat, which is 1 over risk difference, or number needed to harm. These are very useful statistics. Sometimes in the world of genetics, we use the odds ratios, or if you're reviewing retrospective studies, you'd use odds ratios. We actually don't recommend doing systematic reviews of what we call case control studies, retrospective studies. We think they can be very misleading. Then hazard ratios, which is treated statistically like a relative risk. That's coming from a life table type of analysis where you're measuring time to death, not just death. So this is another review from one of my students. This is looking at exposure to antibiotics in pregnant women or in the early life of the newborn, and the effect on asthma. The theory is it increases the risk of asthma. These are 3 panels based on how many antibiotics were used based on courses, and you can see that there seems to be an increased risk, and it increases with the amount of antibiotics taken. And again, each study estimate is laid out here, a crude estimate and the adjusted estimate that takes into account confounding for each study. This is using the adjusted estimates. For continuous measures, we use a mean difference, and then the weighted mean difference, again, should be common statistics in animal research. You might not use standardized mean difference. This is where people are using a very similar type of measure. So it might be a type of IQ measure. Someone else uses a similar type of IQ measure, but it's not exactly the same. Then you could use a standardized mean difference. So this is an example here. This is a Cochrane review. It's looking at the triglyceride level in millimoles per liter. So these are the mean differences for each of these studies. That's a weighted mean difference. This is actually looking at the effect of exercise on triglycerides in diabetics. So it's suggesting some benefit from exercise in reducing triglyceride levels. So sensitivity analyses are often done in systematic reviews. You might change your inclusion criteria for studies. You might include or exclude some of the studies. You might reanalyze data. All of this needs to be done very carefully because I told you earlier that reviews have a protocol, or maybe I didn't tell you that, but anyway, reviews do have a protocol, and in Cochrane they're actually published. So these types of reanalysis need to be specified in the final review as being done post hoc. You know, something in the analysis, something in the way of doing these studies has made you want to do basically change your protocol. As long as you're doing it post hoc and declaring it's post hoc, then it's fine. So back to this one that I showed you before, it actually excludes, I'm not sure if you can see it, but it says excluding on 2005. And there was some reason to be a bit suspicious of this study. So this analysis, it computes the meta-analysis, including the study, and then it looks at it without that study. And again, it's all done very explicitly. But this is a form of sensitivity analysis. We have issues of whether you use a fixed or random effects model. Statistically, this is something that's been argued about now for 25 or maybe even 30 years. There's still no really authoritative view about it. We tend to use fixed effects. In our work, it's also called assumption-free. But random effects is used by many other people, and I wouldn't be critical of it. It's important to remember that the choice of statistic can actually influence the interpretation of results. It can affect issues like statistical significance. And it can influence whether you've got heterogeneity. This is a very large set of trials. These are all trials looking at a drug called rosiglitazone, and it's asking the question, do patients who've used rosiglitazone have an increased risk for cardiac for myocardial infarction and cardiac death? And this is an analysis looking at exactly that set of data. That was actually the data that produced this result, 1.27. But you can see here 4 ways of calculating the same data, and only one of them produces, well, this produces a higher estimate than the other ones. And this happens to produce a statistically significant effect when the other ones don't. Now, the real conclusion about this would be that this is statistically very non-robust. But unfortunately, in the world that we live in with drug regulation and so on, FDA, all of that, whether things are statistically significant actually does matter. And in this particular controversy, the previous, it was Nissen and Wolski published using the Pareto odds ratio. They didn't publish using all of these or any of the other ones, which was a bit misleading. Now, maybe the overall conclusions don't change, but I should also tell you the Pareto odds ratio is actually never used. It's almost never used in meta-analysis, and there are reasons for that. And so it was always a little bit curious why these authors chose that particular statistic to report their results and not any of the other ones. Relative risk is actually the one that should be used. So that's why statistics can influence results, choice of statistics. Causes of heterogeneity, you've got random variability, confounding, something perhaps in the experiment confounding, you've got bias, differential exposure, or different doses can cause heterogeneity among studies. That's what this is talking about. Why do you have in a group of studies heterogeneity? A statistical method, and then these factors that perhaps most of you are used to thinking about, different genetic profiles in animals, different injury models and so on, and different physiology. What do you do about it? You don't ignore heterogeneity, but you might not form, you also should not perform a random effects model as a way of trying to get rid of it, because that's not the answer. What you should do is check the data are correct, maybe not do a meta-analysis, try and find out the reasons for heterogeneity, check the influence of the effect measure, and try excluding some studies. It's called an influence analysis, which you saw an example of. I'll miss that. So I just want to talk briefly about this and I'll be finishing. Cumulative meta-analysis. This is where trials are ranked chronologically and a meta-analysis conducted every time there's a new trial published. Many of these were done retroactively, but in an ideal world, you will be doing this prospectively as new evidence, new trials, new experiments get done. And it shows you the weight of evidence as it is continually updated. This is a classic example by Tom Chalmers, who worked in Boston. This was published on IV streptokinase for myocardial infarction. The typical result down here shows a very strong protective effect of this drug. But the cumulative meta-analysis is what's most interesting for us. And this is showing you what the result is after the first 2 trials, the first 3 trials, and so on. And as you come down here, you can see at some point the estimate of benefit really doesn't change very much. All that's changing is the precision, the tightness of the confidence interval represented by the line. And yet there were some very large trials done here. Here's a trial, GC1, that had 12,000 people added to the cumulative total. So this was a trial of 12,000 people. You can ask the question, should half of those people have been given placebo if people had known what the evidence looked like at that point in time? Now, they didn't. This was done retrospectively. But in an ideal world, you'd be doing this as studies get done. And at some point, you've got to make a decision, enough is enough. We know that this is a successful drug. Look down here. This is ISIS-2. This trial adds 17,000 people. And surely, going from that result to that result cannot be justified in giving, again, about 8,000 people placebo. The animal work has been done by Senna, and this is looking at TPA, a very effective drug for stroke. And what they did was look at the animal data. So this is a cumulative analysis of animal work. And there's some sort of, with a few studies in the analysis up here, it's obviously looking a little bit random, but at no point does this drug not look like it's protective. And by about, I would suggest, 2001, when you're about here, there must be, at that point, enough evidence to support stopping doing any more animal trials and moving on into human studies. And I think in the paper, this is one of yours, Malcolm, isn't it? You make the point that actually some of these have been done after human trials have already started and some have been finished. So this is a very, very nice example of where this type of analysis can reduce the number of animals put into experiments unnecessarily. The Cochrane Collaboration in 2011, I'm almost finished, is looking at this. There are now 28,000 reviewers. This was September 2011. 13 centers, 52 review groups, all in different areas of medicine. I think every area of medicine has been covered. Over 2,000 medical journals are hand-searched for trials. And there are over 4,700 reviews, 2,000 protocols actually in the Cochrane Library. So it has grown enormously from that initial small group in Oxford who launched the Cochrane Collaboration. This is the iconic picture of Charlie Cochrane, and he said, it's surely a criticism of our profession that we've never organized this summary of randomized controlled trials. And this was a man who actually did it, Ian, who's not looking quite as young now as he did then, but with his, I think, Ian told me this was probably one of the prototypes or first examples of a Cochrane library online. And here's Archie up here looking on, making sure Ian behaves himself. So you all should feel that you are sort of launched on I hope, a similar enterprise with the animal work. And if any of you know Bridget Bardot, I'm sure she'd be very happy to encourage you to do more systematic reviews. Danke, or Dank, thank you.